We have Chapter 15, Respiratory Emergencies. Just like any of the rest of the chapters, we're going to start with some anatomy and physiology of our respiratory system. Respiratory system indeed starts outside of our body, where our nasopharynx and our oropharynx, the beginning portions of our upper airway, begin. Moving down a little bit further than that, we have the pharynx, which is in the back where the nasopharynx and oropharynx come together. Moving down further than that, we have the epiglottis. Somebody out there tell me, what is the epiglottis' main function?
Keeping food and water out of the top of the trachea.
Yeah, we're trying to seal off the top of the trachea with the epiglottis. Is there times where that becomes problematic? Just off the top of your head, can you think of any? That picture is pretty well illustrated to show how little space there is there.
So if you're trying to ventilate.
So yeah, if we're trying to ventilate and we're ventilating too quickly, sure, that could be a problem. Somebody else was going to say something.
I was just gonna say, like, smoke inhalation could potentially burn it, and kind of cause issues with breathing.
Absolutely. We'll start to hear some of that stridorous breathing, or even a little more subtle than that, because stridor just jumps right up and says, "Hi, here I am." You'll have somebody maybe, and we'll keep it in the vein of smoke inhalation, who comes out of a hot, smoky environment and sort of has this nagging sort of cough and maybe some hoarseness to their voice. That's because those structures, the epiglottis, the larynx, the vocal cords, they've been aggravated, they've been irritated, and that's going to cause some inflammation, it's going to cause some swelling, and there's not a whole heck of a lot of extra space down there for any irritation and swelling. If you have a patient that is exhibiting signs like that after coming out of a fire or, some sort of toxic inhalation, you have an airway that in no way, shape, or form is patent, because if that decides to close, if that epiglottis swells to a point where it's going to close off the top of the trachea is just closed for business, and we have some pretty significant airway obstruction that there's going to be very little we can do with. So our nasopharynx, it's our nasal cavity. This is where most of the air that we intake goes in, tumbles around a little bit, gets moisturized and humidified, gets turned body temperature, and it filters out a whole lot of the particulate that's in the air that we breathe in that nasal mucosa. It's also the home of our olfactory receptors, so our sense of smell, and it in turn will extend into the back of the pharynx, into that hypopharynx in the back of our airway, and that's where the oropharynx and the nasopharynx come to meet. What do we have that we can use in our nasopharynx to secure an airway?
The NPA.
The NPA, measured from the nostril to the earlobe, inserted generally in the right nostril with the bevel pointed towards the septum. Why do we point the bevel towards the septum?
So you don't scrape and damage something.
Yeah, that something is actually on this page. We're trying to protect the turbinates. Those are what's responsible for making that airflow turbulent and making all that air tumble and get humidified and get warmed and get all of the particulate out. Remember, our lungs don't like having any of that stuff in it. So whatever's going to make that process easier is going to, in turn, make both our life and the patient's life a whole lot easier. Moving on down, we have the oropharynx. It is the oral cavity. Air goes in directly through the oral cavity. It doesn't take any real turns. It doesn't do really a whole bunch of much. It does not get moistened as much as the air that we bring in through our nose. The oropharynx extends from the outside, so the beginning of our oral cavity, all the way down to the uvula, that little hangy thing that looks like a speed bag in the back of our airway, and to the epiglottis. What's our major source of airway obstruction with our oral pharynx?
The tongue.
The tongue. What kind of respiratory sound will we hear if the tongue is causing us a problem?
Snoring.
Snoring, yeah. It's going to sound just like it sounds when I'm in bed at night, snoring. How do we fix it?
OPA.
OPA.
Measure,
Yeah,
measure it
absolutely.
from the earlobe to the mouth.
Yep, corner of the mouth to the earlobe with the tip pointed up. We're going to insert it upside down until the hard palate meets the soft palate. Rotate it 180 degrees and continue advance until the flange rests on the lips. That's going to flatten the tongue out and physically pull it forward some. And from there, the snoring goes away. What are some other things that could cause us some trouble in the oropharynx?
Uveitis.
Uveitis, all right. So some swelling and inflammation of the uvula, causing some constriction, causing some airway compromise. Not a whole bunch that we're going to do with that, but there is another problem that we think of with the oropharynx that we can fix, and it's another airway noise we'd be listening for.
Gurgling.
You got it. And how do we fix it?
Suction.
Suction. No more than 15 seconds. On the way out, we're going to suction our patient's airway. Good rule of thumb when you're applying suction to your patient is hold your own breath. When you need to breathe, so don't they. Moving on down, we have the pharynx. The pharynx is where nasopharynx and oropharynx actually connect in the back of our airway. Moving down from there, we have the laryngopharynx. So we're getting into the larynx now at this point, and it's where we have those separate openings to the digestive tract and the respiratory system, respectively. The digestive tract is the esophagus. What is the actual structure that is the beginning of our lower airway? What's that tube called? We have the esophagus in the back and the what in the front?
Trachea.
Yeah, the trachea. The trachea is composed of these cartilaginous rings pictured on the screen right here. They have smooth muscle on the back, more posteriorly towards the esophagus, and we have 3/4 of the way around an actual full form of cartilage. Why is it important that as we get older, that cartilage begins to develop?
It acts as a safety rings to hold our throat in place from collapsing.
Absolutely, it holds things open. It keeps that actually structurally sound. When we talk about the differences in the airway of a pediatric patient versus an adult patient, pediatric patients don't have those really formed, really rigid cricoid cartilages. And not having that means their airway is much easier to compromise with just positioning. Remember, we put that little folded up towel or something between the kid's shoulder blades and it pulls them right into that nice neutral sniffing position, so we can manage their airway a bit easier. Moving on down the road, the trachea splits into left and right main stem respectively at the carina. That is the lowest most point of the trachea itself. It's in the bottom of the screen here. We have the left main stem bronchus that goes to the left lung, the right main stem bronchus that gets to the right lung, and those will continue to split into bronchi and then get smaller and branch off into bronchioles and then get smaller and go out to each individual lobe of each lung. The left lung has how many lobes?
2.
All right, what about the right?
3.
3.
All right, how come there's a difference?
Because the heart sits on the left-hand side of the chest to make space for it.
Bingo, bingo, bingo. And as we split down into those bronchioles, we get smaller and smaller and smaller. We have the exterior portion of all of this bronchioles inside the lungs surrounded by smooth muscle. That smooth muscle can expand and contract to actually change the diameter of these structures. What's happening at this point? Is anything of real merit going on? Are we doing anything as far as gas exchange goes?
Not yet.
Not yet. We don't do any gas exchange until we get down to the respiratory or tertiary bronchioles. We get to the alveolar ducts and eventually into the alveoli, and that's where all that gas exchange happens. This is strictly ventilation until we get down to those alveoli. Ventilation is just the moving of gas. Respiration is when those gases actually exchange and get on about doing the business of creating energy. Here's what it all looks like. This is actually the view you would see, or your paramedic partner would see, when they were getting ready to intubate a patient. The top of the picture here, we have the very more posterior portion of the tongue, and right here is the epiglottis. Just superior to that, we have both of the vocal cords. And when they're going to intubate a patient, they take the tube and they put it right down Broadway, right down the middle, through those two, sort of the upside down V that you can see in the middle of your picture. And that is a 100% secured airway, because we now have a plastic tube from the outside to the inside that is actually physically holding that airway open and giving us a 100% secured airway. Not really something that we're going to be involved in. How do we, when we're assessing an airway, what are some things that we can do to evaluate and say that an airway is patent?
See if the patient's talking.
Yeah, if my patient's talking to me, they're conscious, they're alert, they're maintaining their own. So now let's move on to a bit more of the difficult portion of that. What if my patient's unresponsive and not maintaining their own airway? How do I ensure that it's patent?
Breathing, listen to
Chest rise.
breathing, chest rise and fall, head chin tilt lift.
There you go. Now we're getting into the airway. I get what you're saying with making sure we see chest rise and fall, because generally speaking, and not with 100% surety, but generally speaking, if we see chest rise and fall, gas is going somewhere. But the head tilt chin lift and the jaw thrust will open my airway. You have basic maneuvers to now clear that airway, make sure there's no obstruction. We can suction, we can put in an airway adjunct. And by the end of doing those couple of things, we now have an airway that is open, clear, and secure when our patient's not maintaining their own. When the trachea and the windpipe, the trachea and the esophagus actually come together in the back of our airway, the trachea will actually extend downward and more anterior than the esophagus. It extends down and towards the front of our chest, and it branches at the carina, like I said. That is round about the level of the 5th thoracic vertebrae, so kind of right in the middle of your rib cage. We're still just moving gas. We are in now the left and right main stem respectively. Air is just entering into the lungs at this point, where the blood vessels and the bronchuses and the nerves all enter into each lung. That is called the hilum. That is where things actually come into contact with lung tissue for the first time. As they enter the lungs, they start to branch off. That left and right main stem bronchi, they kind of just extend out almost like fingers, and we start to get into the secondary bronchi that go out to the lobes of each lung separated. And then those eventually will get down to tertiary bronchi, and they eventually will get to bronchioles. They get to the smallest divisions of what the left and right main stem bronchi start as. We still haven't done a thing. We're getting down a little bit closer at this point because we've now gotten to the respiratory bronchioles. So if we're starting to talk about respiration, we're getting in the neighborhood of gas exchange. We finally branch off to each respiratory bronchiole into the alveolar ducts, and those ducts are where we eventually end in clusters known as alveoli. Now, when you see pictures of these in the book and on the slides, they have a very distinct shape to them, don't they?
Yes.
Yeah, kind of
Yeah.
reminds me of cauliflower.
Cauliflower or like a bunch of grapes, right? Now, think about that is when we start talking about the actual physical exchange of gas. If you were to trace around every little one of those ridges and every little bit of that cauliflower, it would take forever, right? Because when we look at cauliflower or we look at a bunch of grapes, we have a lot of surface area in a very small area of space because we have all of those ridges and all of the nooks and crannies like an English muffin. That's why alveoli are shaped the way that they are. That's really what they look like, because it increases the amount of surface area that's available for gas exchange at those alveoli. So if I have more surface area, I can exchange more gas. If I have a decreased surface area, I'm not going to exchange as much oxygen and carbon dioxide because there's not as much space for that to actually happen. The alveoli are those tiny little sacs shaped like cauliflower or a bunch of grapes, and this is where the gas exchange actually takes place. In each lung, there is approximately 300 million alveoli, and that is just a ridiculous number. You know, you have over 500 million alveoli between your two lungs, and I can say if somebody gave me $1 for every one of those, I probably wouldn't have gotten out of bed at 5 o'clock this morning. Those alveoli, there's a ton of them, and that increased surface area gives us a lot of space for the gas exchange that we need to create energy. Exchanging oxygen and carbon dioxide back and forth is what lets us create the amount of energy for every single tiny little cell, microscopic thing that makes up our body, makes up every tissue that we have. The alveolar capillary membrane is what lies between the actual alveoli and the blood. It's very, very thin. It's one cell wall thick, and that actually helps that oxygen and that carbon dioxide diffuse back and forth. Anything that makes that space bigger than that one cell wall thick, what is that going to do to gas exchange?
Decrease the efficiency.
Yeah, it's going to decrease the efficiency. It's going to make it more difficult. Some of the conditions we're going to talk about today are things that will either decrease the amount of surface area of the alveoli by breaking down some of those walls and limiting some of that surface area. Some other things that we're going to talk about today are conditions that will actually expand that space and give oxygen and carbon dioxide more room that they have to try and make that diffusion happen over. And there's going to be some certain give and take in the body if diffusion isn't happening efficiently. Now, I know yesterday when we talked about this a little, very, very briefly, there was a couple guys who were still a little confused maybe about the difference in pressure. And I'm going to come up with something today while you guys are at lunch that will hopefully help to clear that up just a little bit. What happens when we inhale? These muscles all contract. I'm using energy to make that happen. The intercostals, the diaphragm, the intercostal muscles contract, pull my chest wall out. The diaphragm contracts, pulls superior and anterior, so down and forward. And I have made this vacuum, this closed space, bigger in size because it is sealed. There's no access from the outside to the inside except through our oropharynx, our nasopharynx, and our trachea. So it is a vacuum, it's closed. When I make that space bigger, I make the pressure inside of there smaller. When I make the pressure go down, gas from the outside is just going to come in because physics. That's why. It's just what gases do. Just like they go from high concentration to low concentration, they also are going to go from high pressure to low pressure. It's to just keep things even. Everything likes to be at a nice even keel in our body, in the environment, and when those things are maintained, things go well. So that decrease in pressure inside my thoracic cavity actually makes the gas rush from the inside to the outside. And when that gas rushes from the inside to the outside, it increases the pressure inside of my chest. It expands the lungs and it equalizes that off with the atmosphere outside. So now my lungs are full. Those alveoli have lots of oxygen. They are oxygen rich. The blood that comes from the right side of the heart is oxygen poor. That gas exchange, remember, high concentration to low. So the gas comes out of the alveoli. The oxygen gets onto our red blood cells. The carbon dioxide is high concentration in the blood, low concentration in the alveoli. Moves off of the blood and into the alveoli. All of that freshly oxygenated blood travels on its way back to the heart. And the next thing that happens is all of those muscles relax. My thoracic wall, my intercostal muscles relax and go back to their resting state. My diaphragm relaxes and goes back up into its resting state. And I have now made my lungs smaller and increased the amount of pressure inside of that vacuum, inside of this closed cavity. Making that pressure greater forces the oxygen out. And since all I did was relax to make that happen, exhalation is a passive process. Some things that we'll talk about in a few minutes are how our respiratory cycle is actually triggered, what begins it, what our body responds to, and what you'll see is our normal respiratory cycle starts with exhalation. We start with out with the bad gas, in with the good. People who have some significant respiratory compromise and some real respiratory issues actually start because they don't have enough oxygen. They are stimulated to breathe because they are hypoxic. We are stimulated to breathe because we are hypercarbic. So hyper, high, carb, carbon, IA or IC is in the blood. Hypercarbic drive means your body is actually stimulating you to exhale the bad gas out because of hypercarbia. Did that make sense?
Yeah.
All right. Stop me if I'm torturing you because we can slow down and not, we're not in a time crunch as of today anyway. Things are clicking right along. So every time we breathe, our lungs get bigger, then they get smaller. They get bigger, then they get smaller. Then they get bigger, then they get smaller. That sounds like a whole awful lot of movement, doesn't it? They're not going far, but they are moving with every single breath. And there's a reason that it shouldn't hurt to breathe. There's a reason that when we are doing our B assessment in ABC, that we think about breathing being noiseless, effortless, and painless, because it's supposed to be those things. Breathing is supposed to be very unremarkable when we look at it, if it's working the way that it's supposed to. When we start to hear things like breathing is noisy, or breathing is a lot of work, or breathing is painful, clearly we know that we are dealing with some form or fashion of respiratory compromise. But what we're going to talk about right here is what may cause that breathing to actually physically cause pain. Now, we've talked on and off about these two pleural linings. We have the visceral pleura and the parietal pleura. The visceral pleura is a lining that covers the actual lung tissue itself. The parietal pleura covers the inside of the rib cage. And between those two pleural linings, we have what's called the pleural space. It is a potential space. Potential meaning that they are really, really, really close together, but they don't actually touch. And since they don't touch, it allows those lungs to just expand when we take a breath and contract when we exhale. And they move very, very freely, very, very fluidly, and they just glide past one another. So we don't have any friction, which doesn't generate any heat. And by not generating heat, we don't have any inflammation. And that's why breathing is absolutely painless, even with the amount of movement we have going on inside of our chest cavity. What do you think happens when that space switches from being a potential space to actually being filled with something?
Pressure increases.
Say that again?
Pressure.
So yeah, we'll have some increased pressure. So if there's actually something filling that potential space, that space that's really supposed to be close to it, so close together that almost no space exists, and something gets in there, something like a hemothorax, so we have blood leaking into that pleural space, or a pneumothorax, and we have air leaking into that pleural space, or a hemopneumothorax, and we have air and blood leaking into that pleural space. All of that is taking up a space that's actually not even supposed to really exist, and it's filling it with something. And if it fills that potential space, that pleural space between parietal and visceral, what's going to happen now every time we breathe?
The lungs are gonna not have as much space to expand, right? So they get like smaller.
So they will get smaller, especially over time. But initially, since now something is occupying that space, they're going to rub. And if they rub, they're going to generate friction. And if they generate friction, they're going to generate heat. And if they generate heat, there's going to be inflammation. And that inflammation is going to make it painful to breathe. When we were listening up in the upstairs classroom last week, and you heard that pleural rub, somebody said it sounded like a chair being dragged across hardwood. It's actually the sound that those two membranes that are supposed to be noiseless, effortless, and painless make when there's something in that pleural space, and that something is now making it painful to breathe. Your patient will probably be able to tell you, oh, it hurts when I take a breath in, and they might even be able to point to the spot. And it just sort of is another little notch on your assessment saying, well, that's kind of weird. It hurts when they take a deep breath in. You start doing your pluses and minuses, and you realize that there's probably something going on here. You use your stethoscope to listen to those lung sounds, and when you get your stethoscope near where they tell you it hurts, you hear a and you don't need to be able to diagnose what it is, but facts being facts, it's a problem, right? When we look at breathing as a whole and in its simplest fashion, like I said, should it be unremarkable? Sure. You don't generally look at somebody who's well and think, boy, they're breathing like a runaway freight train. You look at somebody who's breathing normally and it's just very, very regular, nice and steady, good chest rise and fall. Air goes in, air goes out. Air goes in, air goes out. It's very regular. It doesn't cause pain. It doesn't make a ton of noise. You guys all saw that firsthand when you, on I think the second day of class, we were listening to lung sounds, and everybody was saying, well, it sounds like nothing. It's really what it's supposed to sound like. It's supposed to sound like air is just moving freely. If we start to hear things like that pleural rub or some of the other lung sounds that we'll talk about and we've already heard, then we can point almost directly at what the problem is. And some of the things we actually have tools in our toolbox to fix. So blood flows into the lungs in two ways. And this was weird for me when I first learned it. You would think the lungs, their job is to oxygenate blood. So they wouldn't have to send blood back to the heart to actually get their oxygenated blood supply because, well, their job is to oxygenate blood. So they probably just pinch directly from the source, right? They actually don't. The only job of the lungs is to oxygenate that blood, put it into the pulmonary veins through systemic vascular, like through the systemic pressure that's built up in our vascular system, and send it back to the heart. So the way blood gets into the lungs to be oxygenated is not the way that those tissues actually get their blood to create their energy. The pulmonary artery takes blood from the right side of the heart, brings it to that alveolar capillary bed. The gas gets down to those alveoli. We're only one cell wall away from one another. The oxygen moves out of that high concentration in the alveoli into the low concentration in the blood, and the lungs send that blood, now freshly oxygenated, directly back to the left side of the heart. We get to the left atria through the pulmonary veins. The left atria sends down to the left ventricle. The left ventricle now pumps that blood out through systemic circulation through the aorta. And when the lung tissue itself needs to create energy, it gets its actual blood supply to do that from the bronchial arteries and veins. Those bronchial arteries are actually what supply the freshly oxygenated blood from the left side of the heart to every cell and every bit of tissue inside of our lungs. So yesterday when we talked about shock, that hypoperfused state, the lungs, the heart, and the brain are three of the last organs that the body will let suffer because of hypoperfusion. But sooner rather than later, if hypoperfusion persists, those bronchial arteries aren't going to get their oxygenated blood supply. And what aren't those tissues in the lungs going to be able to do?
Exchange gases.
Exchange gases and create energy. You're spot on. If that gas exchange isn't happening, energy is not going to be created efficiently enough. And now we'll start to see the lungs not able to hold up their end of the bargain. And that's when we'll start to see some of that decompensated shock and that respiratory rate starting to slow back down, even though our patient didn't get better. So you see how these things sort of just feed one another? When things are going great, everybody gets to eat, everybody's having a grand old time. But when we see things like our shock patient, who we know none of the things that we did were going to really make them, quote, better, we're just fighting time at that point, starting to have that change in their vital signs, that change in their respiratory rate, that change in their heart rate, that generally you would see, all right, cool, my respiratory patient who has asthma or emphysema, and they were breathing 40 times a minute when I got here, and I put some oxygen on them, hoping that it would make them better. And now instead of 40 times a minute, they're breathing 24 times a minute. That patient probably got better. But when we look at some other things, shock for one, I put oxygen on my shock patient, but I know I didn't fix the cause of the shock. I did I laid my patient down, I finished my assessment, I kept my patient warm, but I know I didn't fix what caused the shock. If I see that respiratory rate now starting to work its way back down, that's at the point in the game where I say this is going to work its way back down to 0 if we don't arrive at an emergency room very, very soon. And that's when I have to start preparing for my patient to really begin to deteriorate. So let's talk about normal breathing here for a minute or two. What do you guys think normal breathing means?
Effortless.
Effortless,
Effortless, soundless,
diffusion is taking place properly.
equal chest rise.
You guys are saying all the things that I wanted to hear. So equal chest rise and fall. It doesn't look like a lot of work. It just looks smooth and regular, not too fast, not too slow. Somebody said diffusion is taking place. What are some things that we can do just by looking at a patient to see diffusion?
Obviously, if someone's cyanotic, that's a sign they're not getting enough oxygen through.
Absolutely. So skin color, temperature, and condition is going to
Cap
tell
refill.
me about how my patient is diffusing. Cap refill is going to tell me about how my patient is perfusing. And those things together are going to give me a pretty general idea of how well some of these body processes are actually working. Now, nothing is written in stone. Just because it's working pretty good for the moment doesn't mean it's going to stay that way. But simply just by looking at my patient, I can say, yes, that looks fairly normal. That looks pretty regular, just because it doesn't look like anything that's wonky, right? It doesn't look like something that I would look at it and go, wow, why are they doing that? And really, it's almost how easy it is to evaluate normal breathing. So I know I repeat this a lot, and I know there's still some confusion with it, and I'm gonna try and clear that up today. So our normal inhalation is all of those muscles contract. My intercostal muscles between my rib cage contract and they pull everything anterior, they pull everything out. My diaphragm contracts downward and outward towards the anterior portion of my body. And the size of this chest wall has increased. And even if right at this very given moment in time, you think of it as increase in size means decrease in pressure, and decrease in size means increase in pressure, I'd be happy with that. So since I increased in size and decreased in pressure, gas flows in from the outside. As long as I've had enough movement so that good chest rise and fall, we're going to get gas all the way down to the alveoli. If I only have a little increase in chest wall size and I don't have good enough chest rise and fall, what's that mean about how much gas is going to get in?
It's not enough because it's very shallow.
Yeah, shallow, not enough movement. Not enough movement means not enough gas got in. Remember, the first 150 milliliters of space or so, the first 150 milliliters of like actual volume that we take in, all it does is hold our airway open and move. It doesn't actually provide any gas exchange, no energy creation, nothing. So we have that good chest expansion. We have good rise of the chest. We got plenty of gas in. We got all the way down to those alveoli. We created our increased concentration and gas exchange happens. The back half of that gas exchange is carbon dioxide moves out of our blood and into our alveoli because the blood has a lot of carbon dioxide in it because that's the byproduct that it picked up. The alveoli themselves have next to none. We don't intake a whole lot of carbon dioxide when we take a breath in. So those alveoli are now carbon dioxide rich, and we are going to exhale. All those muscles that I just contracted and used to pull my chest wall open, by reflex, just relax and go back to their resting state. So I made the space, I made the amount of space smaller, so I made the pressure itself bigger, and that pressure now will force air out through my glottic opening, out through my oropharynx, out through my nasopharynx, and that is how an exhalation happens. So I used muscle energy to make one of these things happen. I used muscle energy to make inhalation happen. So that means inhalation is going to be deemed an active process because I actually had to use energy to make that happen. Did I really have to use any energy to make exhalation happen?
No, you didn't have to voluntarily use energy.
Nope. All I had to do was just let nature take its course and those muscles all relaxed. And that's why exhalation is a passive process. Another couple of things that we'll talk about today is use of accessory muscles and people turning exhalation, which we just said was a passive process, into an active process. So we know that inhalation takes muscle energy. I actually have to spend sugar and oxygen to make that inhalation happen. What do you think happens pretty quick for our patients who turn exhalation into an active process by using extra muscles or making those muscles work harder and spending energy stores so they use actual oxygen and sugar to physically force those muscles to contract harder and turn exhalation into an active process?
It's just adding to oxygen deficiency.
Yeah, it's adding to demand, which we already know that we don't have enough of, so it increases the amount of deficiency. You're spot on. And by using those muscles now twice as hard, our patient is going to start looking probably a little distressed, maybe. That's how we look at somebody and decide, boy, that looks like a lot of work, because they are now doing double duty to make it so that that gas gets out. Asthma is a perfect example of that. Our asthma patient has a hard time being able to blow off enough carbon dioxide to actually now have any more space inside of their lungs to get oxygen in. And if I can't fill those alveoli with oxygen, they're just going to remain carbon dioxide rich. Am I going to exchange any oxygen? Are we ever going to get that high concentration of O2 inside of our alveoli?
No.
No, we're not. And our patient is going to then, sooner rather than later, fill their lungs almost all the way to the top, all the way to the apexes with trapped gas, just because they couldn't get enough gas out. So when we hear our asthma patient wheezing, okay, fine, we hear wheezes on exhalation. They start getting a little worse, maybe we start hearing wheezes back and forth, so in and out. Soon enough, if your patient waited a really long time to call 911, we may put our stethoscope to their chest and hear absolutely nothing, because they are so full of trapped gas that they couldn't get out. They could not force that out anymore, that there's no air going one way or the other at that point. Everything is just packed full. All right, we're going to go for a few more minutes, and now we'll talk about abnormal breathing, and then we'll take a short break. So, abnormal breathing generally falls into one of three categories. So we have increased width, lack of perfusion, or a problem filling the alveoli, or the alveoli may be causing a problem for themselves by filling of some other sort. So increased width means there is more space between the alveoli and the blood vessels. Think of anything right now that you can that would increase the space between the alveoli and that capillary bed where that gas exchange happens. What could be there?
Blood and air.
Blood and air. So if we have, let's see, what did we talk about yesterday? Heart failure a little bit. If we have that left-sided heart failure, we're going to have blood start to build up in that capillary bed. If blood is building up in that capillary bed, we're actually increasing the space between the alveoli and that capillary bed where the gas exchange is supposed to happen. So now instead of just having to go that one cell wall, the oxygen molecule that's inside of our alveoli has to go out of that cell wall, across a river of blood, and then still has to get to the red blood cell in order to reoxygenate that blood. And since the heart's not really pumping effectively, that blood has nowhere to go. And we start to see a backup into the lungs. So our increased width, if we're going to talk increased width between the alveoli and the capillary beds, we're going to listen for a lung sound. And what do you think that lung sound might be? Fluids in the way.
Gurgling.
Yeah, we'll start to hear some gurgling or crackles, really.
Crackles.
Gurgling, remember, is upper airway. Crackles are in the lower portion. They sort of sound the same. Crackles is really only heard with your stethoscope. Now let's think of some other things that could cause some increased width. I'm sure everybody's heard the term COPD, right? Chronic obstructive pulmonary disease. We'll talk at length about that here in just a few minutes, but that is a disease people wind up with from smoking. One of the flavors of that disease is chronic bronchitis. Chronic bronchitis has the same pathology of regular bronchitis. So you get that nasty chest cold. It feels like it's hard to breathe. It hurts a little, that kind of thing in the winter, right? Except the thing with chronic bronchitis is, with all the treatment in the world, all of that mucus and all of that infectious material and all of that inflammation from all of the coughing and constantly being covered mucus never goes away. When people that don't have COPD, that don't have chronic bronchitis, get bronchitis, they take a Z-Pak for 5 days and their bronchitis goes away. Our chronic bronchitis patient, since all of those things stay down there, they inflame the tissues of the alveoli. And when those tissues get inflamed, they actually swell and get bigger. So now we have an increased width. We have those alveolar walls now are thicker and diseased and more difficult for the gas to penetrate, and the oxygen has to travel further in order to get from the inside of that alveoli out into that capillary bed, and it makes diffusion more difficult.
So when you say increased width, you're talking about the pleural space?
So it's not even the pleural space. The pleural space is a different animal altogether. When we talk increased width right now, we are really referring to anything that makes the space between the alveoli and those capillary beds bigger.
Okay.
Because those pleural linings are, remember, they're outside the lung. When we're talking increased width here, we're talking inside the lung where gas exchange happens.
Okay, thanks.
Yep. The next one, we're going to talk lack of perfusion. So if blood isn't getting to those alveolar capillary beds, those pulmonary capillary beds, for any reason, there's not going to be any blood available for gas exchange to take place. So remember yesterday when we were talking about obstructive shock? And we had those big swollen out distended jugular veins. And we were talking about the heart not being able to fill with blood. And since the heart can't fill with blood, it can't pump blood to the lungs and it can't pump blood to the body. But the heart's still going to continue to contract. We're still going to have that pressure for a little bit anyway, sending blood back through the venous system, because every time the heart squeezes, a pressure wave goes out, and the venous side of our vascular system is going to keep functioning. There's one-way valves in all of your veins. And every time the heart squeezes, the valve opens, blood gets closer to returning to the heart. That's when we'll start to see those swollen, distended jugular veins. But guess what's not being fed any blood? We're not going to have any blood leaving the right side of the heart, right? Because we can't get any blood back to the right side of the heart because that obstructive shock has closed off the inferior and superior vena cava. So the heart's not refilling. If the right side of my heart's not refilling from that obstruction, every heartbeat sends no blood through the pulmonary arteries, which means no blood gets to that alveolar capillary bed, which means no high concentration, low concentration difference, which means no oxygenated blood goes back to the left side of the heart, which means no oxygenated blood gets pumped out to the rest of the body. And it is all just based on that lack of perfusion. Blood is not being supplied to that capillary bed for our gas exchange to happen. And last but not least is the filling of the alveoli. Anytime those alveoli on the inside get filled with anything that's not oxygen or carbon dioxide, we're going to have a problem. Alveoli, when they fill with fluid internally, or they fill with blood, or they fill with pus from something like pneumonia, it's taking up space. And it's taking up space that was meant for oxygen and meant for carbon dioxide to transfer past one another and just be replaced. So if there's anything in those alveoli that is interfering with this whole process, it's going to make gas exchange more difficult. All of this boils right back to, were we able to create an increased concentration of oxygen in the alveoli? Was that increased oxygen concentration in the alveoli able to now diffuse into the blood, and was that blood pumped round and round? That's why anytime we talk respiratory, we talk cardiology sort of at the same time a little bit, because in order to support perfusion, respiratory and cardiac need to work together. All right, how's everybody doing out there?
Good.
Hey Tom, I have a question.
right,
Yesterday in class, you said things were going to get easier, so I just was wondering what you meant by that.
So once we finish up sort of respiratory and cardiology, we get a little bit further away from the difficult anatomy, a little bit further away from the difficult physiology, pathophysiology. Once we understand the way the cardiac system works, the way the respiratory system works, and the way shock plays a hand in all this, it really is a whole lot less, bamboo shoots under the fingernails.
Perfect.
So we're going to take our time through today, and then a lot of the things that we talk about moving forward is a lot more common sense. If A, then B, if B, then C. Nailing down these three things, and think about it like this. There's 5 grading things on the National Registry. airway, breathing, and ventilation, cardiology, medical, trauma, and operations. So we've done the airway portion. We're working our way through the breathing portion right now. We're going to get on to cardiology either today or tomorrow. And once we sort of nail those things down, a lot of the other stuff falls into place with it, which is why I'm perfectly happy to spend all morning for the most part doing this rather than have to worry about, did it get understood? But you guys are holding down your end of the bargain on that anyway. So asking a question like that makes me think that there's some confusion. So if there's some confusion, we can go back. So let's clear the air here for just a minute and say, is anybody wildly confused by the things that we talked about so far? See, I don't hear any answers.
I mean, I think it's just going to take a lot of time, at least for me. A lot of reiteration and continued studying to really nail down how it's all actually working and to actually be confident to talk about it and really understand it.
No problem. And I'll answer any question you got. And I'm not afraid to say, geez, I'm not sure and have to look something up. So if you come up with something that I don't have the answer to, I promise I won't BS you. I'll do the legwork. But if this is at least making a little bit of sense so far, we're doing well. All right, cool. Let's take a break. And when we come back, now we're actually going to get into some of our respiratory conditions and assessment of breath sounds again, and we'll wade a little deeper into the muddy waters. So I'm going to give you 15. I have 9:37, so we'll say 9:52, somewhere in there. How's that?
Heard.
Good.
All right, everybody, we're back from break. You guys back and ready to go?
Yeah.
All right, so here we are getting back after it. We're going to talk about assessing breath sounds again. This is an important skill. It is important for us to do this on every patient. I suggest you take a set of breath sounds when you're doing your breathing assessment during your ABCs and routinely as part of your vital signs. It gives you a quick look initially as to what could be going on with a patient, because you guys have all listened to and heard what normal is supposed to sound like. We busted out the mannequin, and there's some video stuff that's been available to you guys that tells you what weird actually sounds like. And it's quick, it's easy, and it is something that should be routinely accomplished on everyone.
Yeah, I listened to that one last night, that Strider sound. That was actually pretty horrendous.
Yeah, it's awful, isn't it?
Yeah,
And,
it really was bad.
And that really is the sound of an airway that is well on its way to becoming unmanageable. When you hear Strider, we are late to the party. That is an airway sound it should be frightening from your perspective for your patient. because that airway is swollen to the point now that there is so much constriction that it is making noise. And that, no es bueno. When we talk about assessing just regular lung sounds, though, we're still looking for some pretty significant noises, and most of the time that's going to point us towards what our actual problem might be. So the 4 spots on the front of the chest, the anterior breath sounds, are going to be mid-clavicular above the breast, mid-clavicular below the breast, and then mid-axillary just above the last rib. Why are we listening in those spots specifically?
To listen to the bottom of the lungs where fluid and stuff like that can accumulate.
You got it. We are trying to listen to all of the spaces of the lung. It's not like we're going to, move our stethoscope 1/4 of an inch and listen to every single square inch of lung tissue. We'd be there forever. But if we listen mid-clavicular above each breast, we're listening to the apexes of the lungs, so the tops. If we listen mid-clavicular below each breast, we're listening to the middle portions of the lobes of the lung. And if we are mid-axillary just above the last rib, we're listening to the bases of each lung. Now, Mike, that was you, right, that just said that?
Yes.
You mentioned something about fluid and things accumulating, being in the bases, and you are absolutely correct. Things are going to follow the path of least resistance. Gravity will pull, especially if our patient is either standing up or sitting upright. Gravity is going to pull fluid to the bottoms of the lungs. So if we do listen to our patient's lung sounds, and we hear pretty clear lung sounds up in the upper areas, and we hear those crackling noises in the lower lobes of the lung, yes, my patient does have fluid in their lungs. They do have something causing that crackling noise. But if I hear crackles up here or up here, what is that telling me about my patient's lungs?
They are full of stuff.
Yeah, they have even more of whatever that is that's causing that noise. And now it's encompassing almost all of the tissues of the lungs. Gravity is no longer able to fight this fight for our patient. And we'll hear crackling all fields. We'll hear mid-clavicular above the breast, mid-clavicular below the breast. We'll hear mid-axillary crackles. And the same thing goes for when we listen to our patient's chest and we hear this noise here. Wheezing means that we have a lot of constriction. If I hear wheezing in just the lower lobes, okay, fine. My patient's probably got some sort of asthma problem going on. We're dealing with some form of reactive airway disease. But if I hear now wheezes mid-clavicular below each breast, or wheezes mid-clavicular above each breast, what's that telling me about my patient's lungs?
But there's an airway obstruction.
Yeah, there's an airway obstruction in the lower airway. Remember, asthma is a disease of I can't get gas out. What happens to cause that constriction with an asthma patient is
Inflammation.
inflammation's part of it for sure. And those smooth muscles that surround our bronchioles and allow them to change in shape and size, sort of like our vascular system. We have those smooth muscles that expand and contract to make things either bigger in diameter or smaller in diameter. We will have bronchospasm with wheezes. We have those smooth muscles actually will constrict and contract and make those bronchioles and make those bronchi a lot smaller. And then, Alex, you said constriction. You said inflammation. One of the other problems with asthma is we have that bronchoconstriction, we have increased inflammation and mucus production, and it makes things now very, very narrow and plugged up. So that's why the gas has a hard time getting out. Pressure is going to make that gas go in, But when we have all of that constriction, we have bronchioles that are way smaller than they're supposed to be. We'll hear that wheezing noise on exhalation. And then we have our last one. Right over here, we have rhonchi. That sounds just like a chest cold sounds when you have one. It is kind of just gross, bubbly, lots of secretions in some of the larger structures of the airway. And it just sounds like kind of a junky cough would sound. It sounds like there's a lot of lung butter down there, making it difficult for the gases to exchange and causing our patients respiratory distress. So we have treatments available to us for a lot of this stuff. So rhonchi, that's probably some form of infectious process. So there's not really much we're going to do to maybe correct or reverse that. Sure, we can treat our patient with some oxygen. If we see respiratory failure or arrest versus respiratory distress, we can ventilate. But what do we give to a patient when we hear wheezes and we're thinking constriction and asthma?
EpiPen.
Albuterol.
So albuterol first. I'm not going to tell you that you're wrong with the EpiPen because that's in our protocols as well. But let's start thinking albuterol when we start thinking asthma. We want to give them their albuterol inhaler. We're going to have them use it as directed by their doctor. And what does that albuterol do? Anybody know?
Take a shot probably helps set down some of the inflammation.
It does. It dries up some of the secretions. It tamps down a little bit of that inflammation. But the big thing that it does, remember, asthma is technically called a reactive airway disease. It's caused by bronchospasm. Those smooth muscles around our bronchi spasm and force those bronchi and those bronchioles to contract. Albuterol is actually a relaxant to those. Albuterol forces that bronchoconstriction to go back. And if we open up those airways, what did we fix?
The exhaling part of his breathing.
Yeah, our patient now is able to move gas more freely because we have made those bronchioles and those bronchi the size that they're supposed to be. And we've opened things back up, and our patient now, instead of telling us that they feel an extreme tightness in their chest, is going to tell us that it's easier for them to breathe. And it's all because we supplied them the appropriate treatment to relax those smooth muscles, clear up all of the secretion, take down some of that inflammation, and right there in front of us with just something that is well within our protocol to put our grubby little hands on and provide to our patient, we've corrected their problem. And then we'll talk crackles. So Mike, you were talking about the lower lobes of the lung having fluid in them, and then when we were talking about the higher up we go, the more fluid there is and the worse it is for our patient. What do you think something we can do for this patient? You think they're going to want us to lay them down?
No, they'll suffocate.
No.
Yeah, they'll flood, right? So positioning is going to be a big thing when it comes to some of our respiratory patients.
It's like a full flower position,
Yeah,
90-degree angle.
Pulled upright on the stretcher, 90-degree angle, as high in the stretcher as they can be, because gravity is helping them breathe better. So if gravity is helping them breathe better, we need to help gravity help them. And they're going to want to sit straight up and down on the stretcher if they can, because it's going to allow some of that fluid to pool and allow some of that fluid to get out of the higher up lobes on their lungs, so that at least we have a little bit more lung tissue to work with. All right, so now we're getting into respiratory distress. And we're going to do a bit of medical terminology here first. We have hypoxemia, hypoxia, dyspnea, and apnea. So if we look at these words, we'll break them down.
That's not confusing.
Well, if you look at them slow and one at a time, we'll start with hypoxemia. What's hypo mean?
Low
Low.
What do you think the word ox means?
oxygen.
All right. And then IA?
In the blood.
In the blood. So now look at that word after we break it up into little itty bitty bite-sized pieces. We have low oxygen in the blood. So all that really means is that blood that was supposed to be oxygen rich after the gas exchange isn't as oxygen rich as it could be because there wasn't enough oxygen available for that gas exchange. So we'll have a decreased amount of oxygen in the blood. That's at sort of the alveolar level. Now, if we go hypoxia, we're talking low oxygen in the tissues. So that means now there's less oxygen being delivered to the tissues. So if we have less oxygen in the blood and less oxygen being delivered to the tissues, we're going to have some form of respiratory distress. It's just, and it's not really crazy important to understand, is it low oxygen in the blood or is it low oxygen in the tissue? Is it low oxygen here? Is it low oxygen there? It just means the body's not adequately being supplied. Go ahead.
So if I'm understanding this right, so it kind of would start with hypoxemia. So you're getting low oxygen in the blood, which is then going to turn to hypoxia because obviously if there's low oxygen in the blood, now the tissues aren't getting it. Is that correct?
Bingo. Hypoxemia means you're not breathing adequately. Hypoxia could mean either you're not breathing adequately from respiratory distress, or something is causing that oxygen supply at the tissue level to not be available. So you're absolutely right. Hypoxemia is going to lead to hypoxia just by process of elimination. If breathing is inadequate, tissue perfusion is going to be inadequate and cause hypoxia. And then the last two, dyspnea and apnea. So PNEA means breathing. We'll start there. We'll start at the back half of this word. PNEA is anything that has to do with breathing. What does the prefix of this word dyspnea sort of sound like? How about
Distal?
dysfunction? Huh?
Oh,
What are
never
you gonna
mind.
say? No, say it.
No, I said distal.
Not so much, but at least it was a guess, right? Dyspnea. How about dysfunction of? Problem with. Dyspnea really just means difficulty breathing. And apnea, anytime there is an A in front of as the prefix of a word in any type of medical terminology, it means bad. It means lack of. That's why cardiac arrest means heart's not beating at all. Apnea is really just the $10 medical word for respiratory arrest. That's why when we work on station 1 and you have your 5 to 10 seconds of checking a carotid pulse and feeling for chest rise and fall, I'll tell you all the time your patient is pulseless and apneic. Apneic means they are in respiratory arrest. They are not moving anything because they're not breathing, which will eventually lead to hypoxemia, hypoxia, and sooner rather than later, cellular death because we're not perfusing. So looking at this guy right here, what are some things that you can look at right off the bat and say kind of look funky with just your general impression of him?
He
Stuff
is struggling to
struggling
breathe.
to get. Yep.
He is. He's he's definitely not sitting in a comfortable position, but it's probably most comfortable for him.
I'm not sure, but I think in his hands it looks like he's hypoxic.
Yeah, I would say he's probably got some changes to his skin color, temperature, condition, right? We're seeing probably some cyanosis.
Does the Fowler position help with the recovery for breathing?
Sometimes, a lot of times it just sort of helps them feel a little better. It might not actually really be accomplishing a real like attainable goal.
Would
But
you put them in a position that they feel most comfortable in?
yep,
Okay,
absolutely.
thanks.
So now let's talk about,
It looks like he's using maybe some accessory muscles as well.
yeah, he's definitely got some accessory muscle use going on. We see some retractions above his clavicles. Now let's take a look at his arms. Look how skinny his arms are. And look at how defined his chest wall is. Look at how like you can actually see almost pectoral muscles. I'm figuring Grandpa here isn't spending a whole lot of time down at the Planet Fitness working on his bench press, right? So what we're seeing here is someone who for a long time has made the passive process of exhalation an active process. This is someone who's had a long-standing respiratory disease, and he's now getting sort of a barrel-chested appearance, but the rest of him is kind of wasting away. Why do you think?
He's working hard to try to inhale to get the oxygen he needs.
So inhale and exhale.
Yep.
So why do you think that would make his arms so skinny and probably the rest of them pretty kind of frail looking?
Because his body for however long has been focusing on sending more blood and more oxygen and glucose to the more important body parts.
Absolutely.
Correct.
So his body has now made, and maybe probably some life choices have made breathing so much work that the body just ignores everything else, because breathing is obviously one of a few very important processes that need to happen. It's become so much effort and demands so much oxygen and so much glucose that all this patient does is spend energy breathing so that he can create more energy to spend energy breathing. So this is a really common presentation for people that have had sort of long-standing respiratory compromise. We'll see changes to their entire body because really their body is just concentrating on out with the bad air, in with the good, and making gas exchange happen.
So something like this would be more kind of like someone who's got if I'm using the right word, like hypoxic drive. Their body's just kind of compensating something more chronic, and over the years, their body's just kind of gotten used to it till it reaches the point that now they're in distress.
You got it. This is someone whose body is definitely responding to that hypoxic drive. They have switched long ago to, I take a breath in because I am chronically hypoxic. My blood is chronically hypoxemic, and I don't have enough oxygen, so I need to bring more in so that that gas exchange can happen. And that's what happens with that hypoxic drive. All the rest of us, we have an ample and adequate supply of oxygen all the time. So if our body relied on that to breathe, we'd die. Our body says, hey, we've created a lot of energy. We've had a lot of this gas exchange. There's a high level of carbon dioxide floating around right now. We need to blow some of that away. And when we exhale and blow all that extra carbon dioxide away, our body says, all right, that's good. Now we'll bring in some more good stuff. And we bring in some more oxygen, fill up our alveoli. We have that gas exchange. And then, 5 or 6 seconds later, all of that energy has again been created a whole bunch of carbon dioxide. And the body says, hey, we got an awful lot of this carbon dioxide kicking around down here. Why don't we blow some of that off? So we exhale. After we exhale, we inhale, the active process, contract all those muscles, expand my chest wall, fill up those alveoli, oxygen's in high concentration down there, the gas moves across through diffusion, and it just continues on and on and on and on. And really, what you just said to me was one of the dysfunctions that we see that causes shortness of breath. Inadequate gas exchange or inadequate stimulation of the receptors. Patients who respond to hypoxic drive because they don't have enough oxygen in their blood to support them, it is a chronic medical problem from things that cause shortness of breath. Things like asthma, pneumonia, CHF, or COPD will switch to a hypoxic drive situation to stimulate the patient to breathe faster, to get more oxygen in. They will actually, you'll see shortness of breath chronically, like this guy right here. You can bet your last dollar that he will have a low O2 saturation. He will chronically complain of some form or another of shortness of breath or feeling like he can't catch his breath. And periodically, his chronic problem turns into an acute problem, and he winds up in the emergency room on a 12 lead with a nebulizer mask on, probably sick as a dog. And we would have found that right in the very beginning because of what you just asked a couple seconds ago about the look of his hands, the cyanosis. Even if this guy had a shirt on when we got to his house, we'd see blue fingers, and people aren't supposed to be blue, so that's a good place to start, is we're seeing the effects of this respiratory problem causing a lack of perfusion and causing now hypoxia down at the tissue level because we didn't have the receptors stimulated appropriately, or we didn't have gas exchange happening the way that we wanted it to. That inadequate gas exchange, when we talk about that, if we have things that have now increased the space between the alveoli and the capillary, or we have something that's disturbing perfusion or something that's disturbing ventilation, we're not going to have adequate gas exchange because either gas isn't being delivered appropriately or gas isn't being diffused from the lungs appropriately. And we'll see problems with a patient having some hypoxia there. What do you think could be a mechanical disruption to our breathing? Think easy on this one. Don't reach into the Wayback Machine. What could be a
Some
mechanical?
kind of like airway obstruction.
Perfect. Airway obstruction.
Trauma to airway, the trachea or something.
Yep. Trauma to the airway, trauma to the muscles of the chest wall. Some of the less common would be something like a neuromuscular disease like ALS or something like that. One of the other things we can see is like a pneumo can be a mechanical disruption because
What
it's
about would viral or bacterial, anything like that, causing inflammation and stuff like that to the airway? Would that count as that as well?
yeah, because we're still talking obstruction at that point, right? If something is interfering with the airway's ability to ventilate, because the upper portions of our airway are strictly for ventilation. So anything that is making that gas not be able to get from the outside to the inside is going to be linked to some sort of mechanical cause.
Quick question, Tom.
Yeah.
When you have some kind of spinal cord injury, I forget which vertebrae it is that connects to your diaphragm, would that be a mechanical disruption?
Sure. And since you just asked, I'm going to look that up. So it's the phrenic nerve, and it originates between vertebrae C3 and C5. So any cervical spine injury between C1 and C5 has the ability to cause a mechanical disruption because the brain and the diaphragm no longer talk to one another. So if the brain can't make the diaphragm do what the diaphragm is supposed to do, because the phrenic nerve or the spinal cord has been injured, we're going to have mechanical problems because we can't now contract those muscles. And if I can't contract those muscles, I can't make my chest wall bigger. If I can't make my chest wall bigger, I can't make the pressure inside smaller. If I can't make the pressure inside smaller, gas is not coming in from the outside unless somebody dressed like an EMT that hopped out of the back of an Everett fire ambulance is ventilating me with a BVM. Our mechanical disruption is going to need some pretty significant assessment and treatment, really based on the fact that their body is physically unable to, for one reason or another, get gas from the outside where it's nice to have it to the inside where we need it to be.
Perfect. Thank you.
Yep. So here we go. We're getting into what some of these problems are and how they present to us. The first one we're going to talk about is emphysema. So here's a picture of what our alveoli look like. On the left, we have a normal alveoli. And on the right, we have a diseased alveoli from emphysema. So if I take my highlighter here and I trace around all of the surface of this alveoli. Remember, after yesterday's little art show, that I am no artist. So we're tracing. You see, this is taking me quite a while, right? Because I have a lot of distance to travel. And this is just one tiny little cross section of the alveoli, and there's 600 million total between both lungs. But if I have emphysema, and I'm going to trace around this alveoli, it takes a whole lot less time, and I'm using a whole lot less pretend yellow marker. Because I have decreased surface area, I have decreased space for that gas exchange to take place. Emphysema causes destruction and breakdown of these alveolar walls, and it gives them less nooks and crannies than they had initially when we were born, and that will cause decreased surface area to be available. And if I have decreased surface area available, I have a decreased spot for this gas exchange that I need. Some of the stuff you'll see is most of the respiratory stuff we talk about when we talk about chronic respiratory conditions that aren't asthma. Smoking is generally the most number one public enemy when it comes to our lungs. The alveolar walls break down, and if those alveolar walls break down and we decrease the surface area, this is one of our patients that will retain carbon dioxide and switch from normal breathing like we do, hypercarbic drive, to a pathological process, hypoxic drive. They breathe all the time because they are short of breath. And it's all because they have limited the amount of space that the alveoli now contain to exchange oxygen and carbon dioxide. It causes a huge disruption to the gas exchange, and it makes breathing a whole lot more difficult. Our patient with emphysema, a lot of the times, will actually turn exhaling into an active process. So we actually we'll see these patients have to actually contract their muscles to get enough carbon dioxide out so that they can continue to breathe. And if they are having to contract those muscles to get their lungs to decrease in size enough to get that gas out, they've now made something that was supposed to be for free cost energy. And if it's costing energy, we'll see a lot of the times they wind up either very, very tired from breathing, or depending on how sick they are, they'll have a prolonged expiratory period. Why would it take this patient longer to exhale?
They're trying to get rid of more carbon dioxide.
Yeah, they're trying to get rid of more carbon dioxide, and they made it work. It's not supposed to be work. This was supposed to be free. But instead, they've turned it into something that is actually energy demanding, and the body has to work at actually making it happen. So it will take them longer to blow off the carbon dioxide so that they can keep breathing.
So during exhalation, they're trying to blow off more carbon dioxide, but they're actually just using more oxygen in that
Yep.
process.
Absolutely. Which just makes the hypoxia, makes the hypoxia, the chronic hypoxia worse, and just continues to feed their respiratory problem. These are our patients who will be thin, frail looking, but have that barrel-chested appearance because now they're making accessory muscles that aren't used to doing it work out. And they'll have that actually clearly defined chest muscles because they've turned a passive process that was just supposed to be relaxing into an active process. They'll kind of have a dry, hacky, non-productive cough. There won't be any sputum. There won't be anything coming up when they cough. It's just an all the time cough.
Tommy, I got a question.
Yeah.
I don't know, I'm just thinking about it now. So people with overreactive or underreactive thyroid, I'm just thinking about it now. They tend to have like larger bellies and then smaller limbs. Does this play into that at all, or no? Is the thyroid just its own thing that causes that?
The thyroid's its own thing. Depending on if it's hyperactive or hypoactive, will sort of depend what you look like. A hyperactive thyroid releases too much hormone.
So
And
it affects your metabolism?
Yeah, you wind up being rail skinny because it changes your metabolism and you can't keep weight on. If you have a hypoactive thyroid, which means it's not releasing enough hormone, it's when you wind up with uncontrolled weight gain, and there's really nothing you can do to fix that.
Okay.
Let's see. Emphysema, diminished breath sounds. Why do you think that this patient's chest would sound quieter? Why do you think their breath sounds would be diminished?
Less gas exchange actually taking place.
Less gas exchange for sure. And really,
And
when
the volume's lower.
the volume's lower, and when you spend all of that time inhaling a superheated toxic gas down into your lungs, it actually makes the lungs less elastic. They don't actually expand and contract like the way that they're supposed to. And if they're less elastic, we're actually not filling them as much. And we're not, even though they're working to squeeze it out, they're not really getting as much out. So when we listen to their chest, it sounds a whole lot quieter. You may hear wheezing, you may hear rhonchi. A lot of these chronic respiratory conditions, again, the ones that aren't asthma or congestive heart failure, anything termed COPD, so emphysema, chronic bronchitis, those kinds of things, you can hear almost anything when you listen to this patient's chest. You will hear the wildest lung sounds that there ever was because their lung tissue is diseased. Their lung tissue has gone through many years and many pathological changes that is just making breathing for them a lot more difficult. Here's a good picture of those defined chest muscles we talked about. Like, look at his chest here. You can see his intercostals. You can actually see the spaces between each rib because those muscles have had to work so hard there. He's shredded at this point because he has done a whole lot of work. Not because he wanted to, because he had to. One of the things we'll see with emphysema patients is what we call pursed-lipped breathing. So when an emphysema patient is really struggling, and having some respiratory distress, it'll almost look like they are trying to blow out through a straw. So their lips will be pursed like your patient's almost blowing you a kiss. And they're actually trying to create a form of back pressure to help them exhale more gas. It's a respiratory patient. We're talking emphysema here, so it stands to reason that they'll have some difficulty breathing. But our emphysema patient is oftentimes pink. We don't see that cyanosis a lot of the times with our emphysema patient. They'll be breathing fast and they'll have a fast heart rate for all the reasons you would imagine they would. We're trying to get more gas in. We're trying to move that gas around faster. Tachypnea and tachycardia. Why do you think they'd be sweaty?
Because they're using more energy and it's creating heat.
Everything is energy, is energy demand right now for them. And it is so much effort that they're actually breaking a sweat from breathing. And then this tripod position. This is a really good picture right here of someone in the tripod position. And this is something that a respiratory patient a lot of the times will find them in this position, and they may or may not even realize that they're doing it, but this is the body actually trying to help itself. When we see a patient lean forward like that with their hands on their knees and their chest kind of poked out, they've pre-stretched all of the muscles of breathing. They've already stretched their diaphragm a little bit. They've stretched out those intercostal muscles by pushing their chest out. So that means they don't have to move quite as far to actually expand the chest wall to actually create that pressure difference. So their respiratory status is so poor that they have to sit in this position to make it less work to actually get gas in now. They sit in that tripod position, tensed up with their diaphragm partially contracted, their intercostal muscles partially contracted, and their chest wall partially expanded so that getting gas into them doesn't become as much effort as it typically is. These are our patients that we see on home O2. You got the oxygen concentrator in the living room, you got a full ashtray in every room, and there's 9 miles of oxygen tubing snaking throughout the house. And they're on oxygen and smoking a cigarette out front when you get there. So that was our emphysema patient. That was a look at their alveoli. Now let's have a peek at our chronic bronchitis patient and their alveoli. And tell me a difference or a couple differences that you see between left and right. Left is normal, right is sick.
Looks like the mucus is plugging up the holes a little bit, so everything's not going to be able to move around freely. It's going to make it a slow process, and at some portions it's completely blocked.
We definitely have a mucus plug right here, right? So that means this entire alveoli is closed. And then look at the healthy bit. Look at how thin that wall is right there. And now let's look at the diseased portion. We have all of this extra that oxygen is going to have to move through in order to get onto that red blood cell. So all of that mucus and all of that inflammation and all of that swelling is going to make it more difficult for the gas to get either into those alveoli for the gas exchange to happen or out of the alveoli, because now we have increased space. We have more space between the alveoli and that capillary bed because of all the inflammation and all the swelling and all of the mucus that's restricting that airflow and causing our respiratory distress and maybe leading to hypoxia. Add to that now, the more of this process that goes on, we actually will start to see narrowing of the airways from scar tissue. So even if, they manage to cough up some of that mucus and get rid of it, there's just more mucus waiting to take its place. And all of that constant mucus production and constant rubbing and constant just aggravation of those alveoli just make it more difficult for gas to actually exchange. It's caused by smoking, no big surprise there. We have inflammation, swelling, and thickening of the bronchi and the bronchioles. These are people that when we listen to their chest, will hear that rhonchi in their breathing. They may have a chronic cough, but they will have a productive cough. So our emphysema patient's cough is going to be fairly dry. They're going to cough and cough and cough and cough and nothing comes out. Our chronic bronchitis patient will cough up some of the grossest looking stuff you ever saw. And then 5 minutes later, do it again. And then 5 minutes later, do it again. And then it's a constant. One of the big differences we see with our chronic bronchitis patient versus our emphysema patient is some chronic cyanosis. They are chronically hypoxic. They have limited availability to actually exchange those gases. And if they can't have that gas exchange take place because of the disruption in the space between the alveoli and the blood, they are chronically cyanotic. We will routinely see people that have chronic bronchitis that will have blue nail beds and maybe some bluing of the oral mucosa, so the lips and the gums. And this is how they walk around all the time. These people are generally typically overweight and clearly, just like the rest of our respiratory patients, they're going to have a difficult time breathing. Why do you think that this patient is typically overweight? Take a crack at it.
I'm gonna just say something to do with glucose levels.
So
His metabolism slowed down because he's not getting enough oxygen to produce a faster metabolism.
So think a little easier. What is the problem with this patient?
Not getting enough oxygen
Oh,
in the
so
blood.
they're sending oxygen to the major organs. So whatever organ, I guess, is associated with burning fat and stuff like that, it's not getting enough oxygen. It needs to work the right way.
I'm telling you, man, think easier. Don't get so
Exercise
deep into it.
He's overweight.
probably really sucks.
They don't want to work out.
Don't exercise off.
They can't
They
barely
don't
breathe.
have the ability to do anything other than breathe.
Too much
Breathing
McDonald's.
is effort. And if breathing is so much effort that everything else goes away, these are the people that get short of breath walking from the kitchen to the living room. These are people that get short of breath walking from the bathroom to their bedroom. So we see chronic weight gain in our chronic bronchitis patients because there's no end to the fact that everything makes them short of breath. At least our emphysema patient still has the ability to exchange gas well. They just don't have as much space. So they're a little bit, as long as they have increased oxygen, that's why they're on the home O2, they can still move about and do some things and generally be okay. This patient is so chronically short of breath that the couch is where you'll find them because everything makes them short of breath. The smallest of output is too much oxygen demand. So they just sit on the couch and breathe.
Tommy, sorry to cut you off real quick. I need a couple minutes. I had a little bit of emergency, if that's okay.
Yeah, that's fine.
All right. Yeah, some guy tried to break into our house. I have the police here from the police department.
All right, have at it, Alex. Be safe.
I'm gonna keep it on, but I'll be right back when I can. I'm just filling out a report.
Okay.
All right.
That's the wrong house to try to break into.
No kidding. He clearly.
Imagine if Alex got hands on that guy.
Jesus.
Yeah, he's gonna have some upper airway problems.
The airway breathing and circulation assessment would not go well. The general impression would be bad.
A purple belt in jiu-jitsu, that guy is not going to be breathing.
Not a chance.
All right, you know what? Let's take 5. Yikes. That just totally, that blew my train of thought for real. That's the first time I've ever had that happen. So let's take 5 minutes and we'll come back and finish this lecture off and we'll see where the day takes us from there, all right?
Sounds good.
Sounds good.
Thanks, Tommy.
Sounds good.
Okay, we're back, and I have refocused myself. So, a chronic bronchitis patient, generally they're going to have a productive chronic cough. So it's going to be, excuse me, opposite of our emphysema patient. Our emphysema patient will have a chronic cough, cough all day, nothing comes up. Our chronic bronchitis patient, chronic cough, cough all day, all sorts of chunky goodness is going to be coughed out, but their lungs are just going to keep continuing to produce that. That's why when we listen to their chest with our stethoscope, we expect to hear lots and lots of bronchi. We'll hear lots of rumbling, lots of mucus and crud when we listen. We may hear wheezes, we may hear some crackles, we may hear a lot of stuff, but that coarse bronchi is going to be a pretty good tip as to what's going on with this patient. So, how do you think we treat them? So respiratory distress, right? At the heart of it.
High flow O2, 15
Yeah.
liters a minute.
We're going to treat them just like any other patient that has a respiratory complaint. They're going to get high flow O2, 15 liters per minute with a non-rebreather mask. We are helping their poor gas exchange by putting more gas in. When we give them 15 liters of oxygen, we are increasing the percentage of oxygen that's available in their alveoli. We are making that concentration a whole lot bigger on the alveolar side. So when they take a breath in and they're getting that 100% oxygen, and they're getting 100% oxygen down into those alveoli, we have increased the concentration of oxygen, which means more oxygen is going to diffuse into the blood, which means we are actually sort of overcoming that chronic hypoxia. We are really working to correct the problem that they have regularly. Now that is for your assessment here in class. Remember, if you're in front of a computer, we're going to start small and work high. So we start with a little bit of increased oxygen and see if that helps. And if it doesn't, we give them some more. And if that doesn't help, then we probably switch to a non-rebreather or we switch to a BVM. But for all intents and purposes, when we're treating somebody here in class, high flow O2, non-rebreather mask, 15 liters per minute. But you also do have to keep in mind that oxygen is a drug. So we're going to titrate it to effect when we're actually touching real people.
So with emphysema, you were saying that they're going to start being a little bit more sweaty because it's taking more work.
Yep.
When you apply that O2, are you going to start noticeably seeing the patient cool off and a drop in body temperature as well?
So they may still have some residual from that. They may still have some sort of, it was so much work for so long because they were having respiratory problems that they may still be warm, they may still be sweaty. But what we'll see is the amount of effort that they're having to put in will go down.
They'll start to relax.
Yeah, they'll start to relax a little. Their respiratory rate will start to come back down a little bit. Because since we're putting so high of a concentration of gas in their alveoli, they don't have to work quite as hard. So eventually, yes, we'll start to see they're not as sweaty anymore. They're not really having the same sort of wealth of issue that they had before, but that takes a few minutes. First things we'll see is they relax some. Their respiratory rate comes down some. Their bit of like panicked, oh my God, I can't breathe, starts to get better.
Awesome. Thank you.
Yep. So here is a picture of what our asthma patient looks like from the inside. We have all those smooth muscles going around our bronchioles, and we have bronchospasm causing those bronchioles to get very, very narrow. And when they get narrow, that means not as much gas is going to be able to pass through them. Add to that now, we start to develop mucus plugs and swelling and a whole lot more constriction and problem in those lower airways from this bronchospasm that our patient has a difficult time exhaling. We'll hear those wheezes on exhalation when we listen with our stethoscope, hopefully, because if we hear wheezes on the in and the out, we know that this patient has been quite sick with this bronchospasm, with this asthma for a while, because now it's affecting inhalation and exhalation. We expect to hear those wheezes on exhalation, but if we hear it in both, this is a patient who's been struggling for quite some time.
Hey, Tom, I'm back here.
All right, welcome back to the party.
Thank you. Yeah,
Everything good?
yeah. Some guy. Long story short, just homeless, disoriented. Mental status was not all there. Probably on some type of narcotic, and crawling into my truck and went underneath my house and was putting some stuff he stole from somebody else there, and tried to open up our door and come in. And as he was running down the street, I kind of grabbed him and then waited for the police to grab him. They took him into custody. So one of those deals.
Sounds like an interesting Wednesday.
And it's only Wednesday.
Yeah, kidding, right?
All right.
So moving right along. That bronchospasm, that swelling, that mucus production in the lower airways is going to be causing this patient some significant difficulty. We have a couple of good things for us here, though, is that is reversible. And generally, our asthma patient will know what caused it. They will know what they need to do to make it better. They are generally pretty adept at handling a lot of this on their own. Now, that doesn't mean that they don't wait too long to call 911, because anybody who knows someone who's got some sort of medical condition, the last thing they want to do is call 911 and wind up in the emergency room for hours. So a lot of times our asthma patient will wait, and then be really, really sick when we get there. What do you think our first line treatment is for this patient?
Oxygen.
Oxygen for sure. We're going to increase the amount of oxygen that this patient is taking in with each breath. We find it during the B portion of our breathing assessment. We will notice these problems because they're going to have some difficulty breathing. They're going to have a non-productive cough. If we listen to our chest during our breathing assessment in ABC, we'll hear those wheezes. Our rate, rhythm, and quality of breathing is going to be increased. Why? Because they're trying to take more in. Our heart rate, rhythm, and quality, so C during our ABCs, our heart's going to beat faster. Why? Because we're trying to move all of that extra that we're bringing in with the rapid respiratory rate around quicker. Why do you think anxiety is something that we commonly see with respiratory patients?
Because it's terrifying.
Yeah, call it what it is. Not being able to breathe is scary as all hell. So we're going to see a patient who is visibly anxious, restless, afraid. Our asthma patient generally complains of this right here in some form or fashion. They're going to say, it feels so tight. Why do you think that is?
Because of all the inflammation, the swelling that's going on the inside.
Yeah, it is tight. There's all that inflammation, there's all that swelling, there's all that bronchoconstriction around those lower airways, and it feels tight because it is tight. They are packing their lungs with retained gas because they can't get a good exhale and blow all of that off. If you're going to check your patient's O2 saturation and you give them an increased amount of oxygen, you would expect that this number would go up, right?
Yeah, but it probably won't because the fact that they're having the issues with their bronchis.
You got it. We will a lot of times give them oxygen and it won't really start making them any better until we fix the problem at hand. And we have the ability to do that. Sure, we're going to oxygenate. That's right in the very beginning. That's primary assessment stuff. Oxygen, non-rebreather mask, absolutely. But a beta agonist, albuterol, is a medicine that acts on the beta receptors in much the same fashion as epinephrine does. It just acts differently. So albuterol, they call it a beta agonist medicine because what it does is it goes in and it acts on the beta receptors in the lungs and relaxes those smooth muscles. It dries up some of their secretions. It gets rid of all those mucus plugs because it allows them now to actually cough them out. So if we reverse the bronchospasm with this beta agonist, we dry up all those secretions and they're able to cough and move gas again. When we go back to looking at the fact that they have an oxygen mask on their face, we're going to increase the percentage of oxygen now that is in their alveoli, and we will have reversed the symptoms and the causes of their respiratory distress. When we talk to them about their albuterol inhaler, because this, remember, is an assisted medicine, we're going to give them some pretty good instruction on how to use this. And some of the things that we're going to tell them really are just weird to even think of saying to somebody who is frightened out of their wits and having a difficult time breathing. But the first thing we're going to tell them to appropriately use this inhaler, because most people don't use them right, is to exhale as much as they can. So we're going to take the inhaler, we'll hold it in front of them, we'll have them put their lips around it, and we tell them blow out as hard as you can, blow everything out. And they blow, 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 because we're trying to get as much of that bad retained CO2 out. And then after they get that maximum exhale, we're going to tell them to start to breathe in. When they breathe in, we squeeze the top of that albuterol inhaler and we tell them to breathe as deep as they can and then hold their breath. Why do you think the steps for actually using this albuterol inhaler appropriately are so defined?
Because you have to get it very far deep into the lungs.
We have to get it down to those alveoli. We can't just have them take a little short stutter of a breath and have it just sit there in that dead space and not get down to those alveoli, because if it stays there, it's not going to help anything. We need to get that albuterol down to where it needs to go to work, and we need it to be there for as long as possible. This is almost immediate when it works. We give our patient the blast off their inhaler. Once it starts to work, that chest tightness starts to get better. You'll see them actually begin to relax a little bit. And then you'll see the oxygen starting to help, and you'll see the respiratory rate begin to improve. What's another reassessment we could do after helping our patient with their inhaler?
So
Ask them if they're feeling better.
That's a great place to start. Ask them if they're feeling any better. What's one other thing that we can actually physically check to figure out?
The breathing.
Rate, rhythm, and quality.
Rate, rhythm, and quality. What are we going to include in our rate, rhythm, and quality?
We're going to listen to the lungs.
Bingo. And what should we hear?
Nothing.
Hopefully nothing. Hopefully it sounds a lot better and it sounds like gas just moving back and forth, nice and normal lung sounds. But at least we're hoping to hear that those wheezes have improved some. Because
Yeah, especially when they're breathing in, right? Because if it's starting to sound better when they're breathing in, then you know it's improving.
Right. If we're starting to hear those wheezes even just get a little less severe sounding, because any of these can sound, like loud and clear and holy crap, that's a lot of wheezing. After we give them their albuterol inhaler and we're listening and we hear them exhale and say, oh boy, those wheezes aren't quite as bad. So even if it hasn't improved completely, which it may not, we've improved some, which a lot of the times is good enough to help the patient sort of turn the corner and get better. Next, we're going to talk about pulmonary embolism. So we've talked increase in space between the alveoli and those capillary beds. We've talked sort of decrease in surface area, so less alveoli available for exchange. And now we're going to talk about something that is a decrease in perfusion, a pulmonary embolism. Pulmonary embolism is blockage of blood flow through the pulmonary arteries. And where do the pulmonary arteries come from again?
The right
On
side of the
the-
heart.
Yeah, the right side of the heart. The right ventricle pumps blood away through the pulmonary arteries to the lungs. If we have an embolism, so a blockage in those pulmonary arteries, and the right side of the heart is trying to pump through those pulmonary arteries, but the blockage isn't allowing that to happen, where does that mean the blood's not getting to?
Lungs.
Not getting to the lungs.
Lungs.
So if blood can't get to the lungs, what can't the lungs do?
Diffuse and bring in oxygen. Work
Yeah,
properly.
the lungs will be perfectly operating great. That oxygen will be all filled up in those alveoli. But if there's no blood next to those alveoli coming from those pulmonary arteries to actually now be oxygenated, all the gas coming in the world isn't going to make a bit of difference because there's no blood available for that diffusion to take place. Could be a blood clot, could be an air embolism, could be a fat particle, could be just about anything. But realistically speaking, it doesn't matter what caused it. You guys know what the actual problem is. Our patient with a pulmonary embolism is generally going to have rapid, very sudden onset of difficulty breathing and respiratory distress. They're going to complain of stabbing chest pain that they can almost point to. So when we ask about the OPQ of our OPQ-RST, they'll tell us that it was all of a sudden I couldn't breathe. It feels like somebody's sticking a hot poker right here in this part of my chest. They're going to have a high respiratory rate. They're going to have a high heart rate. They're generally likely to have some cool, moist skin. So where are we finding these problems? Those four problems that we list right there in
primary assessment.
Yeah, that's mental status, airway, breathing, and circulation right there in front of us. And unfortunately, we're not going to be able to correct the pulmonary embolism. You know, there's no magic bullet, no magic pill that we can give this patient in the field to correct this problem. Really, we just operate based on signs and symptoms. And if your patient is complaining of sudden onset respiratory distress, sudden onset of a stabbing chest pain, coughing up blood for no reason, you can see them breathing fast, you have a rapid pulse, you have signs and symptoms of poor perfusion and alterations to their mental status, this is a sick person. At the end of all that, at the end of our ABCs, our primary assessment, this is definitely one of those signs that, hey, we're going to transport to the closest appropriate facility with an ALS intercept en route, because this is somebody who absolutely for sure warrants it. Because is giving them extra oxygen going to be of any help at all?
Nope.
Right, because oxygen's not the problem. Blood flow's the problem. We are going to treat them with oxygen. We are going to ventilate them if they start to go into respiratory failure. Just know that this may not actually fix the problem. We may not actually ever see the fruits of our labor with increasing somebody who we think is having a pulmonary embolism, just increasing the amount of oxygen for them or actually breathing for them. Really, this is the patient who needs to wind up in the emergency room quick, fast, and in a hurry, because that's the only place that's going to be able to take care of what it is that's going on with them. And the last little bit of our talk here on respiratory is going to be spontaneous pneumo. This is, somebody asked me about this the other day, and now that we've gotten sort of the nuts and bolts of this lecture in place, let's talk about a spontaneous pneumo. So a spontaneous pneumothorax is just that. For one reason or another, there has been damage to the structure and function of the lung, and we have gas escaping into the chest wall. That gas escaping into the chest wall is filling up that pleural space. And every time my patient takes a breath in, this leak right here allows more gas to fill up this space. And then every time he takes a breath, more gas escapes. He exhales, the lung gets smaller, and more space gets filled up, and more space gets filled up, and more space gets filled up, until eventually the lung is all but completely collapsed. So does this sound an awful lot like the regular pneumothorax we talked about yesterday?
No, what we talked about yesterday was from trauma and you get a puncture.
Okay. But even with that puncture, even with that trauma,
Oh, like does it do the same thing? Yes.
yeah,
Yeah,
it's
you're still gonna
the
get the same
thing,
result.
right? All that happened here was a sudden increase in pressure inside the lung itself has caused a rupture in the lung tissue. And then that lung tissue is actually doing the exact same thing a sucking chest wound would, or anything else that causes gas to leak into that pleural cavity. So the only difference here is this was a patient who didn't get shot, who didn't get stabbed. Something has caused a dramatic increase in pressure. A lot of the times, our stereotypical spontaneous pneumothorax patient is a tall, thin white male that smokes. Why it is, I'm not really sure. A lot of the times, the smoking is really the big kind of giveaway for this, because somebody takes a drag off a cigarette and they go to cough, but they try to hold on to it. So that glottic opening closes and it won't allow the pressure to be released when they cough. So they wind up having a spontaneous pneumothorax. Why it's tall and thin, I'm not sure, but that is a lot of times what happens. That pressure goes up inside the lung tissue and something lets go. And then the same function. We take a breath in, gas leaks out. We exhale, the lung tissue gets smaller, more gas takes up that space. And then with every single breath, more space and more space and more space and more space and more space. The thing to know about a spontaneous pneumothorax is they're generally pretty self-limiting. Generally, we're not talking our patient who winds up with obstructive shock and tension pneumothorax and tracheal deviation and all sorts of craziness from this spontaneous pneumothorax. Their big complaint is going to be the signs and symptoms. Sudden onset shortness of breath and some chest pain, decreased breath sounds on one side, maybe a little bit of a rapid respiratory rate. This is a patient who, sure, they have a pneumo, but it's not quite as significant, at least on the outset when it starts, as our patient who's got a sucking chest wound and has sustained that trauma. Because most of the time the body takes care of these spontaneous pneumos all on its own. We get called because of the sudden onset shortness of breath, the sudden onset chest pain, patient who feels like they can't breathe well enough. Our treatment is pretty simple. We treat their shortness of breath. We monitor for signs and symptoms of a tension pneumothorax developing. So tension pneumothorax is obstructive shock, right? Who was my group for that yesterday? Am I in the right neighborhood?
Yes.
All right. So what are some of the signs and symptoms I should be on the lookout for my spontaneous pneumothorax or any pneumothorax turning into a tension pneumothorax?
An enlarged carotid artery.
So yeah, no, the jugular veins, you're in the right spot. Just,
Jugular, yep.
so if we start to see those distended jugular veins and signs and symptoms of shock, know that your spontaneous pneumothorax patient has just gotten very sick right in front of your eyes. And how do we fix it? Do we fix it?
In vivo.
ALS.
ALS for sure, because they're going to be able to decompress that developing tension pneumo and stop this patient from being someone who the coroner finds tracheal deviation on. All right, that was respiratory. How's everybody doing after that lecture?
Pretty good.
Tom, I got a quick question about a pulmonary embolism.
Sure.
So if you get that blood clot, say somewhere, and it just starts building up and building up, I think I read or I heard that if you have that blood clot suddenly just disappear and all that blood comes rushing back in, is that a stroke or is that what?
So it's not really a stroke. A stroke would be what if that blood clot was in a cerebral artery, right?
And it bursts. If it bursts, would that cause it?
Or it completely blocked off that artery, your patient would be having a stroke because the tissues past that clot aren't getting any blood. If we have a blood clot somewhere, sometimes the body will just absorb it. The body will be able to break it down and make it go away. Other times it does wind up kind of moving its way through circulation and winding up in other places. And that's why they're sometimes a little difficult to nail down and get a good handle on where they are and where they're headed and all that. Really, the one thing we have that we can do to check for things like that is skin color, temperature, condition, pulses distal to the where the blood clot is and where the blood clot was.
Gotcha.
Because if it's lodged somewhere and affecting perfusion, then it's going to be pulseless and having some signs of hypoperfusion past wherever that blood clot started.
Gotcha. Perfect. Thank you.
Yep, no problem. All right, so I know everybody's probably going to be heartbroken to hear this, but respiratory was our big chapter for today. The only thing we have left, we're not going to do cardiology today because that's just too much in one sitting. We are going to talk about immunological diseases and how we're going to treat the one big one that we're even really going to talk about, which is anaphylaxis. But first, we are going to take another short break because all of that respiratory stuff is really kind of a lot, and I get it. And I want to give you guys the opportunity to think about it for a couple minutes and ask me any questions if you got any before we move on, because there's no sense moving anywhere if there's still confusion about respiratory stuff. So we're going to take 10 minutes. When we come back, we will do immunology. Let's see, I got 11:15, so we'll say 11:25, and then immunological emergencies should carry us right to lunch. But let's talk about immunological emergencies. The big one we're going to talk about here is anaphylaxis. That's what's going to take up the entire half hour that we're going to sit here and talk, is we're going to talk nothing but anaphylaxis. Now, one of my groups yesterday had distributive shock. Anaphylaxis is a type of distributive shock. What we're seeing here is general progression, right? We have normal looking Will Smith up there in our upper left-hand corner. He's itching a little bit, he's itching a little bit, and bam, lower right-hand corner, face looks like he got hit with a shovel. This really is exactly how anaphylaxis will present. We're going to show a couple pictures of some of the edema that pops up with our patients when they've had exposure to an allergen. Because the reason anaphylaxis is an immunological disease is it is the immune system that is causing all of these problems. The immune system is just doing what it does on any given day. It's just doing it to the 10th degree. The immune system identifies something as not supposed to be there. And since the body has been sensitized to this one particular chemical or protein or whatever it is, the immune system just freaks out and calls all cars. And when it does that, all this immune response going on throughout the body creates a systemic reaction. So when we talk systemic reaction, that means multiple body systems, multiple body parts are involved, as opposed to just the one area where people who aren't allergic to bee stings see the signs and symptoms of being stung by a bee. I'm not allergic to bee stings. If I got stung on the arm by a bee, I'd have a little hole from where the stinger went in. I'd have a little raised area. I'd probably have a little inflammation, a little swelling, maybe a little bit of like hives or what they call urticaria. It would itch. And that would be my immune system's normal response to the fact that I just got stung by a bee, because I'm not allergic. When somebody who is allergic to bee stings gets stung by a bee, they have that initial injection. So the bee stings them and injects the same venom into them that it injected into me, but their body has been sensitized to it. Their immune system is primed and ready to go off the next time that that chemical is introduced into that person. When the chemical gets injected by the bee sting, instead of having that nice, just general localized spot where things are a little uncomfortable and the immune system's doing its thing, the immune system sends all of its response far and wide, because holy smoke, there's an invader in here, we got to kill it. And it goes on about the business of killing everything instead. The immune system just overreacts to a normal problem, and in doing so, starts to cause some systemic reaction inside of our patient and starts to take out multiple necessary body processes all at the same time.
Anaphylactic shock is probably one of the shocks that most people are familiar with. It's also known as anaphylactic. Anaphylactic shock is an allergic reaction that's severe enough to cause shock. And of course, shock is decreased tissue perfusion, or in other words, decreased oxygenation of tissues. There are a number of different things that can cause an allergic reaction. For example, bee stings can cause an allergic reaction. Peanut allergies, food allergies, pollen can cause allergic reactions, and so can certain medications as well. Now, of course, allergies can be either very mild and seasonal, such as hay fever, and sometimes allergies can be so severe that it can cause shock. But how does it cause shock? Well, first of all, to answer that, I want to acknowledge that there are two types of anaphylaxis, those that are immunologic and those that are non-immunologic. And I'll go ahead and start with immunologic anaphylaxis, because that's actually the most common type. In immunologic anaphylaxis, there's some sort of allergic agent, whether it's poison from a bee sting or a food allergy, that somehow gets into the system. And whatever this material is, it's known as an allergen because it generates an allergic response. So when this allergen first gets into the body, it will interact with B cells. And not B cells like the insect, the bee right up here, but B cells as in the letter B. Now these cells are the antibody creating cells of the immune system. They create antibodies. And antibodies are essentially a little Y-shaped protein that is used like a signal marker to find something that's foreign material. So in this case, the antibodies will be reacting to the allergen. Now, antibodies that are created in response to an allergen are known as IgE. IgE stands for immunoglobulin E. Globulin means protein, and immuno just means immune. So really, it's immune protein, and the classification is E. Now, the reason I want to emphasize this is because IgE specifically docks onto other immune cells, which are known as mast cells. And these mast cells are mediators of the immune system. So what ends up happening is once IgE is created, it will dock onto these mast cells. So this all occurs when a person is first exposed to an allergen. And this is called sensitization. The immune system is sensitized to this allergen. So the next time that this allergen comes along, it will create a rapid allergic response. The allergen will dock onto these antibodies, and when they do, the mast cells activate. And when mast cells activate, two main things happen. First of all, mast cells release immune molecules known as cytokines. Cytokines are essentially used for cellular communication. So mast cells communicate with other white blood cells and tell them to come over. So what ends up happening is these white blood cells continue to recruit more white blood cells. And it's a cycle that creates more and more white blood cells being recruited and activated in response to these allergens. Now, the activation of both the mast cells and the immune cells causes release of another molecule known as histamine. Now, histamine is a potent vasodilator. In other words, it dilates blood vessels. So here, with the dotted line, I'm showing a blood vessel size before, and after histamine, the diameter of the blood vessel increases. Now, this is happening in the bloodstream in the entire body, and it causes a large drop in blood pressure. So patients lose the function of their circulatory system and are no longer able to distribute oxygen. And so that's how an allergy causes shock. And also let me note that histamine causes blood vessels to become leaky. So fluid escapes the vascular space, which causes swelling to occur all throughout the body. So a patient has massive swelling along with a massive drop of blood pressure. Now, the second type of anaphylaxis is called non-immunologic. Now, non-immunologic anaphylactic shock is essentially the same as immunologic shock. It's just the pathology is slightly different. Instead of mast cells being stimulated by IgE, the allergen specifically targets the receptors on the mast cells. And so you get the same process of histamine release as well as cytokine release, which of course causes this super immunologic response as more white blood cells are recruited, and then also causes this drop of blood pressure. So what are the symptoms that we see in anaphylactic shock? The symptoms are going to be characterized by the actions of histamine. So a patient with anaphylactic shock has this major drop in blood pressure due to vessel dilation. So we'll see flushing of the skin as blood vessels dilate and blood starts to saturate in the skin, and swelling as fluid is getting outside of the blood vessels, and itchiness, which is also caused by histamine release. So these are all symptoms that you would come to expect from an immune response. You may see other various symptoms such as rhinorrhea, which is a runny nose, and this is caused by vessel dilation in the nasal vasculature. So you have an overactive release of fluid. But the symptom that I really want to get to occurs with the lungs. Histamine not only causes vessel dilation, one of its most serious symptoms is bronchospasms, spasms of the bronchi, the main air passages to the right and left lungs. So these bronchospasms make it difficult for a patient to breathe. What makes it worse also is that swelling can be occurring in the throat as well, which can close off the airway, making it even more difficult to breathe. So a patient comes in who's non-responsive, he's not breathing, and you check and find that the patient has a very low blood pressure. So what do? Do you order lab tests? No, that's a terrible idea. This patient is having a severe bout of shock. It should already be apparent based off of the clinical symptoms that this patient has. especially the low blood pressure. Severe low blood pressure should indicate that right away something needs to be done. So you progress right to treatment. And treatment is based off of the ABCs: airway, breathing, and circulation. So number one, you want to establish the airway. If the patient is not breathing, you want to give them 100% oxygen so you can fill up their lungs. And ventilating the patient with a bag mask to push air into the lungs may be one of the first ways to respond to a patient who has anaphylactic shock. Along with this, the blood pressure needs to be maintained. There's one medication that's especially effective at maintaining blood pressure in patients with anaphylactic shock, and that's epinephrine. First of all, of course, patients have these very dilated blood vessels. Now, epinephrine has strong sympathetic activity, so it acts in a way to constrict blood vessels back down to maintain blood pressure. So this directly counteracts what histamine does to blood vessels. Epinephrine also affects the lungs and causes bronchodilation, so it opens up the airways. So this is important to allow airflow back into the lungs. Now, to also maintain blood pressure, IV fluids will help fill up the vascular space. So these are the main ways to treat a patient with anaphylaxis. And along with this, you can give antihistamines to really directly counteract the effect of histamine in the body. But of course, let me emphasize that epinephrine and IV fluids are the mainstay of
All right. I wanted to stop that guy before he got too deep into some of the more advanced treatments for anaphylaxis, because we carry EpiPens on our truck. Epinephrine and oxygen are going to be the two things that we're going to do for our patient who's in anaphylaxis, because right then and there, we are supporting all the functions of airway, breathing, and circulation. One of the things that you probably noticed in the video is when all those chemical mediators and all that histamine and all that vasodilation and bronchoconstriction and swelling and leakiness are happening, not only is it happening in important places, it's happening everywhere. And by introducing epinephrine into our patient with an autoinjector, we are actually now reversing all of those systemic problems. We are treating airway, breathing, circulation. We are opening up the lower portions of the airway and reversing that bronchoconstriction. So we're making it easier for them to move gas in and out. Supplying them oxygen is going to make more gas available for that gas exchange to actually take place. By making breathing easier for them, we just made it less work. So less O2 demand, less glucose demand, less energy expended. By now constricting all of those leaky, dilated blood vessels, we are now making the tank back to the size that it started at, where we wanted it to be in the first place, and we have fixed the anaphylaxis. Now, we haven't removed the allergen, but we have fixed the problem at hand. Downstream, they're going to do things like provide histamines and treat these patients with IV steroid injections and things like that to now continue the good trend and make sure they continue getting better. But the first line treatment, the stuff that we're going to do with a patient in anaphylaxis, is what is going to treat them most effectively and most appropriately first, because if we don't do our piece of this, they never get to the point where histamines and IV steroids and things of that nature are going to do them any good, because they'll be dead. Anaphylaxis is one of the times as a BLS provider or an ALS provider, you can witness yourself save somebody's life. So let's talk about our normal allergic reactions. We have things that our body is not supposed to have in them. Just about anything can be turned into an allergen. You know, he said as simple as pollen. Pollen is an allergen. Pollen, generates an immune response from the body. Anything that triggers the body's immune system into place is going to be considered an allergen. It just depends, is it a systemic allergic reaction and we start talking anaphylaxis, or is it a localized allergic reaction and we start talking about treatment that is supportive or not even necessary? Because generally speaking, people who have seasonal allergies and they get a bit sneezy in the springtime when the trees are starting to bud, Don't call 911 because they're sneezing. People that are allergic to shellfish and peanuts or bee stings, and they get stung by a bee or accidentally eat a peanut or accidentally wind up somewhere where shellfish is, they call 911 because their body is trying to kill them. What can be allergens? Anything. Food, medicine, chemicals, venoms and toxins, organic materials. One of the things, I used to watch a show called, oh God, what was it called? I don't even remember what the name of the show was, but it was people that kept dangerous animals as pets. There was one guy who had a buffalo that he kept as a pet. He had his car all chopped up and cut down so the buffalo could ride in the back seat. But most of the people that they interviewed, it was things like lions and tigers and, you know, some of the most venomous animals, snakes, insects, whatever, that have ever lived on planet Earth. And these people would get bit by these animals, and the venom wasn't actually what wound up killing them. Most of the time when they died, the last time that animal bit them, they had an immediate immune response, anaphylaxis, and died just because they became allergic to the toxin, not because the toxin itself killed them. Most of the time when we think about things that cause anaphylaxis, we're looking at food, medications, and chemicals and venoms. Organic materials, generally we're talking things that are minor localized reactions, things like pollen, poison ivy, dust, mold, things of that nature. They're things that are found all around us that can stimulate the immune response to make us uncomfortable. When we talk about anaphylaxis, 30% of the people that die from anaphylaxis die from a food allergy alone. Food allergies are absolute killers. And one of the big problems with a food allergy is a lot of times they take longer to appear. How come? Why do you think food allergies take a lot longer to present themselves?
Yeah, it has to digest and process through the system of the liver.
Yeah, it takes about 30 minutes for that food to break down the minute it hits your stomach. So not only does it take longer to appear, if that food is still in your stomach breaking down even after the signs and symptoms of anaphylaxis have shown up, we will see anaphylaxis come back even after we give epinephrine, because God only knows how much of that food is still in the patient's stomach being broken down, and it doesn't always have to be peanuts and shellfish. This list right here is far from comprehensive, but it is really just showing us that any food at all can cause a patient to have an anaphylactic reaction. Medications can occur from any route of administration. Generally, IV medications are going to be our fastest presentation of anaphylaxis when we talk drugs, when we talk medicine, because IV administration delivers the med right into the patient's bloodstream, and that allergic reaction, that immune response can pop up, no questions asked, right away. A lot of times with things like oral medicines, antibiotics particularly, those medicines work and function by building up in our patient's system. And the more of that medicine you take, the more builds up in your bloodstream, the more close we get to the immune system actually be stimulated and kicking into response. Oral medications can take a very extended period of time to show up when we are talking about medicine. Chemicals can be severe. We have exposure, it will increase the symptoms over time. Latex is one for sure. The more you are exposed to latex in things like gloves, which thankfully we don't have anymore, the more sensitized your body becomes to it, and the more severe the allergic reaction becomes. This isn't typically what we would consider a huge risk for an anaphylactic type reaction, but it can increase in severity, and depending on if it's something inhaled like a perfume or dust from makeup, we can start seeing some airway compromise. We can start seeing some problems with are integral body processes that are going to make it so that maybe we do need to give our patient epinephrine in this case. Bites and stings, stingers themselves, when we see one stuck in a patient, they can actually continue to inject venom into our patient for up to 30 minutes or more. So your patient who's been stung by a bee, we don't want to grab hold of the end of that stinger in the venom sac and pull it out if the stinger is still there. Use something like a business card or a piece of paper to scrape down the skin to get that out. The venom that's actually being injected is what's causing this allergic reaction. This route of administration can be almost instantaneous. When things are injected into the body, it does not take long at all for that injection to leach its way into the bloodstream and cause our patient to start exhibiting some pretty significant signs and symptoms of anaphylaxis pretty quickly. So here we go. Allergic reaction, just a local reaction. We will see problems starting to develop only at the scene. We don't have that big systemic, oh my God, this patient has no blood pressure, can't breathe, his airway is compromised. Holy smokes. We have a problem where we found it. Histamine is being released by the immune system. It is going to make them itchy. It is going to make them a little bit uncomfortable. It's going to give them maybe a little bit of mild GI upset. But the more things we start to stack up in the negative category, the more concerned you should become for your patient. So if we have more than mild GI upset, you're starting to get a lot closer to your patient who's truly in anaphylaxis rather than having a localized reaction. Remember, the body doesn't care about perfusing anything but the heart, the lung, and the brains when under attack. So the body will begin to close off the vasculature of the GI system, of your gastrointestinal tract, when perfusion is becoming an issue. And anaphylactic shock is absolutely a perfusion problem. Here's our localized skin reaction. This is what they call urticaria. These red, raised, splotchy looking bumps. It's what we would generally call hives. They can be itchy, they can have kind of a burning sensation, really, really uncomfortable. I used to be able to, when we wore latex gloves, I used to be able to do this. I could leave thumbprints on myself just by touching my own forearm with a latex glove. This, again, still, since it's only where the patient actually was touched by the item, is a localized reaction. We're not seeing any of the more systemic signs and symptoms, so we're not as concerned about this. Histamine is involved in the production of stomach acid inside the GI system. So when the body is releasing all of this histamine, we're producing more acid in our stomach. We will see some pain, cramping, nausea, vomiting, some like acid reflux or like sour guts. Some diarrhea is possible. But there's a big difference between if we see just these things alone versus if we see those things in conjunction with hypotension, respiratory distress, airway compromise, signs and symptoms of shock, and some maybe alterations to my patient's level of consciousness. Our treatment for any one of these signs and problems, so our urticaria, our GI symptoms, if we're talking singularly, so we are only seeing one problem, we really require little to no care. Sure, if they call us, we'll put an ice pack over wherever the problem has originated, wherever the allergen has been introduced into our patient. But what we're really looking for with our localized allergic reaction is to make sure that it doesn't get worse. because since a lot of these things do take some time to develop, they do take some time to get worse, we could have an anaphylactic response. Anaphylaxis is a true life-threatening emergency. We have a systemic allergic reaction involving multiple body systems across multiple fronts. That histamine is everywhere in the body, going and running amok and really causing our patient to have that vasodilation, that leaky vasculature, all of that swelling, all of that inflammation. We'll have hives that now, instead of being localized, will be spread far and wide. Our patient will have hives pretty close to everywhere. We'll have some chronic and persistent nausea, vomiting, diarrhea that just continue to get worse. We'll see vasodilation causing our patient to be hypotensive. The body has now encountered something bad and it's rushing blood everywhere to get rid of the bad thing. But the body is also spreading that bad thing everywhere. So the vessels just continue to dilate and continue to dilate and continue to dilate. And all of that dilation will turn into things that look like this: angioedema. So with all of that dilation and all of that leaking, we have swelling in our mucous membranes. Patients' lips and eyes and face will start to look all swollen and sort of disfigured. We'll have patients whose airway swells to the point that they can't get it back in their mouth. Does this look like an airway obstruction?
I would think so.
Yeah, I would say, right? That's about as significant of a reason I would need to give somebody epinephrine. Because if the external pieces of his airway are swollen to this point, what do you think the internal pieces of his airway look like?
Truly bad. Swollen.
Really swollen. And we're probably at this point hearing stridor. We're probably at this point having a hard time with this patient maintaining his blood pressure. And we're going to lead to some respiratory distress. We just spent 3 hours talking about respiratory distress, so I'm not going to beat this one to death. But we are seeing some signs that point us towards, hey, this patient's making a lot of noise when they breathe. It looks like a lot of work. I'm hearing stridor, I'm hearing wheezes, I'm seeing use of accessory muscles because their body is trying to feed itself enough oxygen to stay alive. And the more that these problems continue to progress, the more difficult all of the body processes become. So what do? Our treatment for anaphylaxis is pretty straightforward. We are going to focus on our ABCs. We see angioedema, we see that swelling in the airway. We know that that's going to be an occlusion. If it's not an occlusion right this second, it is turning into one. We'll see tachypnea. They'll be breathing really, really fast because they're having a hard time moving oxygen through all of that leaky all that leakiness and all that constriction of their airway. We'll see hypotension due to their systemic vascular dilation. And guess what? One medicine fixes all of that. Our patient will be exhibiting signs and symptoms of anaphylactic shock. We'll see hypotension, respiratory distress, poor skin color temperature condition. With our anaphylaxis patient, we expect them to be sort of red and itchy, not pale, cool, diaphoretic, because that vasodilation has spread blood out far and wide. So we're seeing blood in the vascular beds. So that's why they're red and itchy and blotchy.
Yeah, I've had that once with some type of dressing I ate, and hives were all over my body, and it started like leaking fluid out of it as I was scratching it.
So whatever that was, don't eat it again.
No, I know, I never did. They did. They just gave me Benadryls, what they prescribed me when I got to the hospital.
Our fix for all of these problems in the field is singular. We are going to give our patient 0.3 milligrams of epinephrine with an auto-injector, intramuscular. We're going to hold that EpiPen against their leg. It's going to click. We're going to hold it there for 10 seconds, and we'll massage the area to help that medicine get into them faster. And then we are going to reassess. Never forget your reassessment. Never forget your patient's 6 rights. Make sure that you have vitals going into all of this, because we don't know if we even should medicate this patient until we have finished our assessment. If your patient is under 25 kilos or 60 pounds, they get an EpiPen Junior as long as they're older than 6 months. If they're younger than 6 months, they get no EpiPen until you've talked to medical control. If they're over the age of 65, they get no epinephrine until you've talked to medical control. We're trying to make these people better, not trying to make their day worse, right? So we have to make sure we dot all our I's and cross all of our T's. What do we do with the epinephrine, the EpiPen, after we administer it? What do you think?
You cover it back up and you make sure you put into one of those red containers for sharp objects.
Right. So the good thing about it is spring loaded and it has a built-in safety mechanism. The bad thing about it is spring loaded and it has a built-in safety mechanism. We don't actually have to recap anything. As soon as you have introduced that needle into your patient, it goes nowhere but the sharp spin. The only part of this EpiPen that can hurt you is the pointy end. So always keep the pointy end pointed at something else and you'll be in good shape. Don't rely on the fact that it's got a safety cap on it, because sometimes, especially because it's spring loaded, the needle will bend and won't retract into the safety all the time, all the way. So you don't want to get poked with that needle. So develop good habits. Always, always, always. A sharp comes out, a sharp goes into a patient, a sharp goes in our biohazard container. That's the long and short of it. We'll play with the EpiPen trainers a little bit when you guys get here. We'll talk for a few minutes about check and inject epinephrine and sort of the steps of actually drawing up epi, in case you guys don't use EpiPens and you actually will draw it out of a vial. And we'll go over some patient assessment when you show up. But other than that, I took us to noontime, and I'll see you guys all at 1.
Cool. Thank you.
Thanks, Tommy.
No problem.
Thanks, Tom.